Hi, good morning or good evening or good afternoon to everyone, depending on where you are in the world. My name is Maxime Cannesson. It's my pleasure to introduce you to the webinar from the American College of Perioperative Medicine. Today, the topic of the webinar is going to be changing your clinical practice with COVID-19, a primer. I want to thank the American College of Perioperative Medicine and Edwards Life Sciences for putting together this webinar. We have three very notorious speakers today. The first speaker is Dr. Nirav Kamdar, who's going to be followed by Dr. Monty Mythen and then Dr. Arthur Martella. We are going to start right away. Dr. Nirav Kamdar is an anesthesiologist at UCLA. He's also an innovator. He's been very involved with the UCLA program on innovation here in Los Angeles. He's also been instrumental with the implementation of a pre-op clinic that relies heavily on telemedicine. Since 2017, he developed this program that became extremely successful at UCLA and that gained even more attention when the COVID-19 pandemics hit the whole world. So today, Dr. Kamdar is going to present us his experience with telemedicine for anesthesiology and surgery, especially in the pre-op phase of care, but also in other phases. And he's going to share his experience on how this could transform the way you take care of COVID-19 patients. Dr. Kamdar, thank you very much.
Thank you, Maxime. I will share my screen as soon as the invitation comes. Excellent. Thank you very much, Maxime. It's such a pleasure to be here this afternoon, and I appreciate everybody in the audience who's there listening from afar and from near. I wanted to start with the question, do you really think that we're going to be evaluating all patients for perioperative consultation from the confines of a clinic room? I certainly don't. I actually think the home is going to be the new extension of the hospital. And COVID-19 just pushed telemedicine and remote patient monitoring over that tipping point. Had I said this about a year ago, I probably would have heard from the skeptics. But I think since early March and even before that out in East Asia, the scene has definitely changed. But when we think about digital futures, we often get the inspiration really from our patients. So I wanted to take a period back to about 12 months ago and introduce you to one of my patients who was a 26-year-old who had von Hippel-Lindau disease. And she presented to an outside hospital with bilateral pheochromocytoma here and a pancreatic head lesion. She was referred to us at UCLA to do a pheochromocytoma excision and a Whipple procedure as a single stage operation, and then take out the second pheochromocytoma subsequently later. Now, this was a young 26-year-old. She was technologically savvy. She was a classic millennial, but she lived 65 miles away from our hospital at UCLA. And so instead of doing the traditional route of perioperative management where we would bring them into the clinic, measure blood pressures, and moderate and manage their alpha blockade, we did a telemedicine visit with myself and the resident and the patient almost 70 miles away. And we sent her a Bluetooth blood pressure cuff so that she could input her own blood pressure and heart rate data. We communicated with her through asynchronous communication throughout this perioperative period. And she felt that that communication link between her and us for a high-risk ASA4 surgical case was definitely convenient to her and safe for her. To go into a little bit more depth, we sent her this Bluetooth blood pressure cuff. It sent the data that she was collecting 3 times a day to her cell phone that then pushed to our electronic health record. And from there, we sent digital prescriptions to her local pharmacy. And you can see here from the details, this is actually her her blood pressure readings and her heart rate readings and the titrations that we were making on her alpha blockade. And we really only physically saw her for the first time on the morning of surgery for a combined Whipple and pheochromocytoma excision. And from the hemodynamics of the case over a 6-hour period, you can see that the case was quite stable throughout the case because of the the successful perioperative blockade. Now, some would say, oh, you got lucky. You got a young, technically connected healthcare consumer or patient. And that might be the case because we do see that the majority of the young patient population does have access to their cell phones, and they're used to interacting with the world around them in a digital way. But I would argue that COVID-19 just pushed even our elderly patients to be using this kind of technology almost by necessity. So what we did at UCLA since 2017 is we did virtual visits. And we started off with Zoom technologies and transitioned in 2018 to a platform that was embedded in Epic. In our perioperative clinic, we conducted 30-minute visits with the anesthesiologist to collect history and optimize the patient and decide if subspecialty consultation was necessary. And if applicable, we would actually use the patient's home devices, smart devices, wearables, and connect them to our EHR system in order to get patient-entered outcome data. And to this date, we've done over 600 of these types of consultations. Now, our anesthesiologists have had a history of using telemedicine. We can think of just the status quo where we schedule a patient, see them in person, and have them scheduled for the operating room. Across the country on the East Coast of the United States at Thomas Jefferson, they actually see patients with telemedicine in series. They first take the history of the patient through telemedicine, then see them in person in the clinic, and then to the operating room. In contrast, at UCLA, we actually triage them either to in-person visit or telemedicine, and that was prior to COVID-19. What we found at that time was that our patients were able to be seen both far in the Sierra Nevadas and Northern California near San Francisco, but more often than not, patients would even want to see us from within the close confines to UCLA, which would be here, and our patients in a metropolitan area were still avidly looking to do telemedicine, even though they lived close by. Our patient satisfaction rates were high, and almost 98% of these patients preferred to do their consultation virtually on a subsequent visit. Now, where did that large patient experience come from? Well, this is a picture of the infamous 405 freeway in the smack center of Los Angeles, and this is a scene of the traffic, which could either be at 5 p.m. rush hour, or it could be at midnight. It doesn't really matter. And what patients experienced was a great amount of time savings for their consultations in the perioperative environment. Now, COVID-19 changed that because this was the scene after the 19th of March. So let's fast forward to the 19th of March. And when we look at telemedicine, we see great changes from that day when safer at home orders were given by our governor. Prior to this date, telemedicine was really restricted both on a national level as well as from compliance. We were only able to see patients from a rural environment. We could only see patients from within our state, and there was limited reimbursement and limited billing for remote patient monitoring. COVID-19 changed all those rules. It expanded the geography. It created payment parity between in-person consultations and telemedicine consultations. We were allowed to do even E&M billing in order to see patients in that manner. As we all experienced in hospitals across the country and across the world, our surgical volumes dropped to 30%, and our outpatient consultation centers were forced to go to 100% telemedicine. But these brought along a few positive trade-offs. One, it helped the psychological safety of our patients who did not want to enter a hospital during the throes of COVID-19 for possible exposure. But it also protected the clinicians and the staff who were evaluating numbers of patients who could possibly be exposed not only by the patients who could be asymptomatic carriers, but also expose one another when they were in a hospital environment. So we were able to do these consultations from home just in the same capacity that our patients were able to initiate the consults from home. If we do a deeper dive into some of the regulations, we could see that after the beginning of April, Medicare and other national bodies waived the geographic limit of telemedicine. We were able to have a much expanded modality from not only video, but phone and some other services. But also it reduced the licensing requirements across state lines and dissolved those, at least temporarily. And it allowed relaxed HIPAA requirements for modalities that were outside our EMR, such as FaceTime and Zoom technologies, et cetera. And that was similar to some of the relaxation of those stipulations from Medicaid. So if we just look at volume, because in anesthesia, we were doing and accustomed to doing telemedicine from 2017, we had a volume even before the throes of COVID-19. And then when we switched to 100% telemedicine, you can see that our volume definitely increased. In contrast, you could see family medicine, which had no billing ability prior to COVID-19, their volume greatly increased after March 19th. And you can see that explosion in the number of evaluations done by this modality. If we take our pain clinics, for example, this was our patient population that we were seeing by telemedicine, seen in these red bubbles by size prior to COVID-19. And that increased to this level across Southern California after COVID-19. The benefits that the patients were seeing was quite a bit from patient savings, not only from parking at an expensive parking lot at UCLA, but also the driving fuel. But we also did an analysis internally where we looked at the time-based savings that the patients would experience. We used an assumption of the median hourly wage of California, which was a conservative estimate of $20.40. But if you think about, and we reran this analysis of looking at patients' median hourly compensation by their originating zip code, and that opportunity savings increases from $45 per person to almost $90 per person. We saw great increases in the value of remote monitoring. I mentioned that value when I was talking about my patient last year, but we've been using more and more tools from consumer-based products and smart devices that were pushing data into the cell phone that then interacted with our electronic medical record that pushed the data directly to our flow sheets that we could review as clinicians. This was not only applicable in the perioperative environment and the chronic pain environment, but we also used it for remote surveillance for COVID-19 symptoms, for the patients that presented asymptomatic but came out to be COVID positive. We would send them back home with a product from our EMR called Care Companion that gave a schedule of data that the patient needed to push into their device. We would have a symptom query for symptoms of dyspnea and fever and chills. And then we sent them home with consumer wearables for oxygen saturation and Bluetooth enabled temperature devices so that we could follow their temperature curves and their oxygen saturation curves when they started feeling dyspneic in order to be able to triage them to come back to the hospital. So what are these future consequences that I predict going forward in the future after the tipping point of COVID-19 pushed telemedicine over that hump of acceptance? One, we have to be cognizant that there's still going to be a digital divide that's present. This is our own internal UCLA data that shows that prior to COVID-19, we still saw an age divide of adoption of telemedicine, a gender divide, and across race and ethnic levels. That was corroborated by our colleagues at UC San Francisco that looked at telemedicine use across race, gender, and ethnicity after COVID-19. And they showed that after implementation of telemedicine post-COVID-19, you saw that same effect where our minority groups were having less access to telemedicine technology. And so it behooves us to be cognizant of this effect, as well as to address it, either by making sure that we have the language capabilities to help patients who are non-English speaking, as well as to think of socioeconomic and even broadband capabilities for people to access this technology going forward in the future. What's my speculation about perioperative telemedicine and telehealth? Well, I still believe that patients will continue to have consults from home. And even today, I'm in pre-op clinic and all my patients decided that they wanted a home consultation. We're going to see extending expansion of remote patient monitoring opportunities. I think we're still going to move forward with reimbursement parity for the in-person visits alongside telemedicine to have them being paid equally, although I think that there will be distinct codes that will come out directly for this. I believe that we'll see an expanded student and resident training in all of our training programs across academic medical centers. But I do think that there's going to be a great reintroduction of the privacy compliance measures that we saw, respecting the laws of HIPAA and other privacy measures that we see not only in Europe, but in the United States as well. So I'm going to hand it back to Dr. Cannesson and say thank you, and I'll wait for the questions at the end of our session. Thank you.
Thank you, Dr. Kamdar. So the next speaker is Dr. Monty Mythen. Dr. Mythen is the Smith Professor of Anesthesiology at the University College of London. He is extremely well known for his work on anesthesia management, hemodynamic management, fluid management, enhanced recovery after surgery, bringing the concept of perioperative medicine at the forefront in Europe, the UK, and in the United States. He has also done an amazing work on the mission Everest, taking physician, anesthesiologists, critical care physician to the top of Mount Everest and doing some of the most impressive physiological studies in extreme situations. So it's my real pleasure to introduce Dr. Mythen. Today is going to discuss blood volume, flow, and pressure are essential for respiration. Monty, thank you very much.
Maxime, thank you very much indeed, and thank you very much to Dr. Kane for the very kind invitation. I would like to echo everything that's just been said with regards to the likelihood that telemedicine is here to stay, very much the change driven around the world by the impact of COVID-19. I hope you can see my slides now. So as you heard, I come from University College in London, so that's UCL, not UCLA, often mistaked. I'm also an adjunct professor at Duke University Medical Center, where I was on faculty over 20 years ago. I do have some potential conflicts of interest, of which the only real pertinent one for this evening's presentation is that I do consult for Edwards Life Sciences, who I believe have very generously organized this evening's event. So as I said, I'm from University College London, so London in the United Kingdom. And to remind you, the United Kingdom has a population of about 1/5 to 1/6 of that of the United States of America. I live and work in London, which is our capital in the southeast, and I'm part of our national health system, which provides the majority of healthcare in the United Kingdom. Now, we have a relatively low critical care bed stock in the United Kingdom, although we run it very efficiently. This is data from our Intensive Care National Audit and Research Centre. It's a report from our cumulative number of patients in critical care up to the middle of April, which is where we were sort of peaking in London. Now, London took the initial wave of COVID-19 patients, and some hospitals were completely overwhelmed within a week or so. We had a rapid expansion of critical care beds, as happened in many parts of the world, such that by the time we were peaking, every bed in London was full, despite having cancelled elective surgery. Every new bed we'd created in every corner that we could find to put a new bed in had been overwhelmed. And we had started to flow over into a 4,000 bedded critical care unit that had been built in a convention centre called the Nightingale Hospital on the eastern end of London. So quite extraordinary times. I was due to start night shifts on critical care, but a bit like some people had during the Great Wars, I took an early wound. In other words, I got COVID-19 and lucky enough avoided hospitalization, but became quite unwell, was looked after at home, managed to survive, and only got back into looking after patients in the COVID pandemic when we started to reboot our major cancer surgery in so-called protected or green hospitals. Having said that, I attended critical care ward rounds on a regular basis remotely, as has just been described, and then once I was feeling better, I got back into the front line. Now, while the title of my talk was a lot of debate early on about how one should manage patients from the point of view of the basic airway, breathing, circulation, and then the clever discussions about critical care. And the title of my talk talks about respiration, because in our rounds, we continue to remind each other that respiration is a cellular phenomenon. It's not breathing. It's not about dyspnea. It's about whether or not you're successfully experiencing aerobic metabolism in all of your cells. So sorry to bring it down to very basics, but oxygen is consumed in our mitochondria to produce energy, which is essential for all forms of life in the form of ATP, and the byproduct is carbon dioxide. Now, a common feature of COVID-19 in patients who required hospitalization and subsequent intervention was hypoxia. Just to remind us what we mean by hypoxia. Sorry, this is very basic, but the reason for this will become apparent soon, is the primary goal of our cardiorespiratory system is to supply enough oxygen to satisfy the metabolic requirements of all tissues at all times. So it is to avoid that hypoxia the cardiorespiratory system is there. And hypoxia is the presence of anaerobic metabolism. Now, one of the early great debates in presentation of patients with COVID-19, that in the hospitalized patient was primarily, not through the non-hospitalized patients, but in the hospitalized patient, was a viral pneumonitis, was so-called hypoxia, whereas actually very many patients were actually experiencing hypoxemia with no evidence of cellular hypoxia. So they may have had low saturations that may have been experiencing for a while, but had no evidence, for example, of elevation of lactate consistent with anaerobic metabolism. So they appeared to be below their anaerobic threshold or their lactate inflection point. Now, those people who've traveled to high altitude or done research at high altitude would know that you can become profoundly hypoxemic without necessarily being hypoxic. Let's remind ourselves that the mitochondria are in charge. So our cardiorespiratory system is there to subserve the appetite of the mitochondria. It's to maintain cellular respiration. So one of the big debate comes then is how low is too low? What is your SATS target when you're looking after somebody who appears to be actually quite comfortable despite having a low SpO2? When you're treating that patient, is your goal the PaO2? Is it the arterial oxygen tension to get it above a particular threshold? Is it the SpO2? Is it to have a saturation above 80, 90, 92, 96, 98? Or is it to maintain what the system is designed for, DO2, which is oxygen delivery? Now, in the whole discussions about the development of COVID-19 from our colleagues in Europe who saw the first major European wave in Italy, a debate started with regards to, is this actually what we've come to call in the modern world ARDS? Well, historically, ARDS was very clearly described. It was an acute onset of severe respiratory dysfunction with the magnitude of AA gradient, so a magnitude of the difference between the inspired oxygen and arterial oxygen across the lungs that was associated with profound hypoxemia, bilateral pulmonary infiltrates that was acute and not associated with myocardial dysfunction. The debate about was COVID-19 ARDS or not, of which it obviously is ARDS in its pneumonitic form, was because many patients who were intubated and ventilated did not have stiff lungs, they had compliant lungs. And in the modern era of using the title of ARDS, it's been predominantly about the stiff lung ARDS. In other words, when intubated, the lungs are hard to ventilate. And many of the ARDSNet trials have been about the stiff lung version of ARDS, whereas this was a compliant lung version of ARDS that we were predominantly seeing. The other question then was this just a pneumonitis? Was it just the lungs or was it multi-system? And now we all know, no surprises with a virus. COVID-19 affects every system in the body, absolutely every system in the body, but it preferentially attacks early organs that have a higher availability of certain receptors, including the ACE2 receptors. So the lungs are very vulnerable, and for example, the kidneys are very vulnerable, and in particular in the kidneys, the podocytes of the kidneys are very vulnerable. But I can tell you personally, I have cutaneous manifestations of having had COVID-19, which if you're not familiar with all the recent literature is now well described, a vasculitic injury producing scarring on your limbs, for example. Now, mixed in with all of that, once it was labeled as ARDS early on, there were questions about, well, should we run these patients dry? one of the great modern truths, which is not actually that evidence-based, is if you're labeled with ARDS as an adult patient, you're intubated and ventilated, that we should try and run patients as dry as possible. Now, to remind ourselves that if you do see a hypoxic patient, there are 4 major subcategories. You can be so-called hypoxemically hypoxic. That is what you get, for example, at high altitude when you have a low inspired oxygen availability, or with a pneumonia, for example, when your problem is getting the oxygen from within the alveoli into the blood vessel. You can have a stagnant hypoxia as a result of a blood flow problem. You can have an anemic hypoxia as a result of oxygen carrying capacity being deficient within the bloodstream. And you can have a cytotoxic hypoxia, which is consistent with a form of cell poisoning. And to cut a long story short, all 4 forms of hypoxia are commonly seen in critically ill patients who have a diagnosis of COVID-19. This is a diagram I just plucked up from Wikipedia to remind ourselves about the relationship between the alveoli and the blood vessels in the lungs. We all know this. We often think in terms in ARDS of the challenge being the proteinaceous ooze that ends up in the alveoli, creating a hyaline membrane and therefore a large AA gradient because of the challenge of getting the oxygen from inside the lung into the blood vessels. Now, in COVID-19 patients, one of the striking features early on was, despite the ease with which one could ventilate the lungs compared to the stiff lung, the non-compliant form of ARDS, was that despite the fact they had a very large AA gradient, so you needed a very high FiO2 to maintain a reasonable PaO2, so a big gap across the lungs from that perspective. There was also a large PaCO2 to end-tidal CO2, so lungs that are relatively easy to ventilate, not requiring much PEEP appearing to be deleterious from causing a differential distribution of oxygenation in a way that was not helping. It was much more like you were looking like at a patient who'd had a pulmonary embolus, so it was much more PE-like. And now we know that the principal problem, as in many viral pneumonitis, was a microvascular thrombotic problem, not necessarily an embolic problem, but a primary clotting of the blood vessels around the body, but in the lungs that was producing the AA gradient, which made it look like a pulmonary embolus. In other words, there was a big VQ mismatch as a result, initially primarily, of thrombosis of the small vessels. So when I talk about the AA gradient and the PaCO2 to end-tidal CO2 gradient, we'll just remind ourselves, there's an old screenshot grabbed off the internet of an end-tidal CO2 monitor, is if a patient was acutely to have a pulmonary embolus, the end-tidal CO2 would drop acutely without a change in the compliance of the lungs because you'd blocked off the blood vessels. So you'd created a ventilation perfusion or VQ mismatch because you dramatically suddenly increased physiological dead space. So now you are ventilating lung that wasn't being perfused, so you had this AA gradient and this gradient between PaCO2, arterial CO2 that's now rising, and end-tidal CO2 that is disproportionately low compared to arterial. And that allows you to diagnose a VQ or ventilation perfusion mismatch. Now, mixed in with that early on in the diagnosis of COVID-19, in many of the reports shared throughout Europe and subsequently throughout the eastern coast of the USA, spreading through the west coast of the USA, was as a result of people running patients dry because they'd labeled them as having ARDS of the classical stiff version and relying on results from the ARDS-NET trials that had been about patients with stiff lungs. Patients were, against a background of having a prolonged period of starvation and dehydration, being run dry. And then you got to a point whereby people realized that that was not a smart thing to do when you had viral pneumonitis with a VQ mismatch associated with a problem on the perfusion side. They eventually got around to saying, we actually need to fully resuscitate these patients to maximize VQ matching and not worry so much about the wet lung being the problem. So it wasn't long until on ward rounds, on rounds amongst the more junior attendings, you'd hear people report back that they gave the patient some volume to get the SATs up. So for older intensivists, we'll be very familiar with this type of viral pneumonitis. For younger intensivists, you might turn around and say, what does he mean I gave some volume to get the SATs up? So as you resuscitate the patient fully, you improve VQ matching, your PaCO2 end-tidal CO2 gradient narrows and your AA gradient improves. So in classical modern stiff lung ARDS, there's often the run them dry, which actually means don't fluid overload them. Then there was the debate about this is not ARDS because it's not the stiff lung type. Well, yes, it is. It's just a compliant because it's a vasculitic problem as opposed to principally a proteinaceous ooze ARDS problem. Then we were starting to see a lot of AKI, acute kidney injury, that largely was probably iatrogenic as a result of dehydration and under resuscitation. So then you have, well, if they've got AKI, you need to fill them up, not run them dry. Remind ourselves as to why that balance of risk lies. If we look at remind ourselves of the distribution of blood flow on the left-hand side, if the patient is euvolemic, you have 100% of blood flow through the lungs, 4 to 5% through the heart. You see the distribution between the brain, splanchnic organs, kidneys, etc., etc. We all know if you do allow somebody to be hypovolemic or run them dry, then although you maintain a heart, lung, brain circulation, you can readily compromise splanchnic circulation followed by kidney circulation, etc., etc., etc. By having the splanchnic circulation under provided with, particularly if you're then doing a lot of proning for your patients to improve your AA gradient, you can bring all the problems of gut mucosal ischemia with regards to translocation, creating worsening lung problems, and that can be nephrotoxic as well. So lots of reasons why early on, in some places, there was quite a high incidence of acute kidney injury that subsequently was still there because there is a viral attack of the podocytes in the kidney, but much less, it would appear, in fully resuscitated patients. So this is a hemodynamic framework, and I think the next speaker is going to much more about goal-directed therapy in different contexts. I'm sorry we haven't shared our presentations amongst ourselves before we've spoken tonight. But this is from the Perioperative Quality Initiative working with the American Society of Enhanced Recovery, and it's a proposed hemodynamic framework for patients undergoing major surgery. And I would suggest to you that it's exactly the same framework that we should apply and often do apply to any patient who presents who is critically unwell, because our principal primary objective is to resuscitate the circulation by giving just enough fluid to restore an adequate intravascular volume, followed by which we restore flow, and then we aim to have, as a result, an adequate pressure. And then and only then do we try and restrict subsequent use of excessive fluids that will result in extravascular water and salt that can cause secondary harm. So the algorithm is the one that we think we use every day of the week. Is there a clinical problem? Combine your available information with your advanced hemodynamic monitoring. Remind yourself that fluid responsiveness is very, very useful. But if everything else is okay, you have a normal MAP, index, lactate, etc., etc. Looks like the kidneys are working fine. Fluid responsiveness in isolation after the resuscitation period is not an indication for additional volume, particularly in the situation of acute lung injury with right heart dysfunction. The next thing you say is, what's causing the problem? Is it just that I'm sedating the patient too heavily, or is it something else like a GI bleed? Use your advanced hemodynamic monitoring, whatever it is you choose and whichever variables you rely on most. And then most important of all, rely on this very special organ here, the brain. So apply your brain to the available information and then treat preload, afterload, and contractility. And many of my colleagues said on reflection after the initial wave of COVID-19 is they think if they hadn't listened to all the rumors and they hadn't got onto the early webinars and they hadn't got into the debates about ARDS, not ARDS, the different phenotype variables, and they just did basic airway breathing circulation, and once they'd got the patient on a basic ventilatory mode, they'd got their monitors out and they'd done basic resuscitation, restoring volume, then flow, then pressure, which they eventually got round to doing. They think they would have done a better job from the get-go. So I'll leave you that final thought. Both blood volume, flow, and pressure are essential for respiration, irrespective of the context, whether it's the emergency room, the operating room, the critical care unit. They're absolute necessities. Thank you for listening.
Okay, thank you very much, Monty. So again, we'll take all the questions for the speakers at the end of this webinar. I'm going to invite the third speaker. The third speaker is Dr. Arthur Martella. Dr. Martella is the Chief of Cardiothoracic Surgery at Virtual Health System in Camden, New Jersey. His practice focuses on minimally invasive and robotic cardiac surgery. They have in this program taken care of a lot of COVID-19 patients using ECMO, using any kind of invasive hemodynamic monitoring. And then today is going to discuss the concept of goal-directed fluid therapy in the critically ill COVID patients. Dr. Martella, thank you very much. Hello?
Hello? Hello?
Dr. Martella?
Yes. Hi.
Okay, you can go ahead.
Hello, this is Art Martella. And I'm going to try to this talk.
Art, I think you are probably muted because we cannot hear you. Okay, so it seems like we are having some technical issue with Art Martella. I'm just.
If you want to just continue speaking, you're more than welcome to right now. I have you on speaker. Go ahead.
Excellent.
Myself, or are you talking to Art?
Got that. And so as I was saying, we're going to give a brief review of our experience managing some of these critically ill COVID patients. And this really started about a month ago, and with a couple of cases that we saw related to COVID. The first one was a 56-year-old male, pretty typical for some of these critically ill COVID patients with a history of hypertension and a week of worsening shortness of breath and fever. He was admitted to the ICU and ruled in for COVID testing. Over the next 72 hours, though, he developed worsening respiratory failure. He was intubated and required increasing PEEP from 12 up to 18, eventually up to 20. 24 hours after initiating mechanical ventilation, He went into renal failure, required CVVH to maintain his renal status. He continued to have worsening respiratory failure, and then had a failed attempt at proning. And at that point, they called us for VV ECMO support. We did standard bilateral femoral vein access. But what was interesting is when we went to flow on the VV ECMO, we found very difficult to flow, and we actually had to give him 3.5 liters of fluid before we could even initiate flow. This really brought up some, glaring issues with some of these COVID patients. They're frequently febrile for 5 to 7 days before they even present. Sometimes they've been aggressively treated with diuretics, often have poor PO intake. And when on the ventilator, they then are started on fairly high PEEP pressures to maintain their oxygenation and ventilation. And at the same time, they frequently will have limited access, CVP, plus or minus an arterial line, and they're older and they frequently have underlying heart disease. Because of all these things, they're really challenging from a fluid status point of view. Managing their oxygenation, volume status, vasoplegia issues, and cardiac function can be very difficult. And traditional parameters, which are available, obviously, are blood pressure, heart rate, oxygen saturation. These may not be enough in these patients. Real-time visibility of balance between oxygen delivery and consumption may assist the management of some of these problems. And we have been using these non-invasive and minimally invasive hemodynamic monitoring in the operating room to manage some of our open heart patients. And we've actually seen significant improvement in our ability to get patients more euvolemic in the operating room with this support. And we thought it might be helpful in these patients. And this is just a view of the hemisphere that we've been utilizing, and it gives you cerebral oximetry, peripheral tissue oximetry, as well as some fairly good hemodynamic parameters such as continuous cardiac output, stroke volume, and SVR. And this is just an example of some of the technology that we were utilizing. And the one thing on the right is to note that the ClearSight also gave us very similar parameters in patients who had access problems. So in the acute setting, particularly with some of our dialysis patients, where we were struggling to get access, we would put this on very quickly, and it would give us at least some numbers to work with. So this is really a brief review of our early clinical experience with these devices. And I will say we're just approaching 10 cases now, so this is really just really anecdotal. But we do think that there's some value in this moving forward. We're excited about rolling this out to more patients. The first case is a 71-year-old male with a history of hypertension, known coronary artery disease, and status post PCI. He presented with increasing back pain, malaise, positive troponin levels, and also positive COVID. He was initially treated with remdesivir, but continued to fail, and he was given convalescent plasma, but again, within 24 hours, he had a cytokine storm, required mechanical ventilation, and at the same time as all this was going on, he was found to have bilateral DVTs. And this is just a view of really the sort of the big picture view of the tissue oxygenation during the 5 days that he was monitored with this device. And you can see there is some variations, but it's not too helpful at 10,000 feet. But we can interpose certain things that were done during this time to see if there was either a positive or negative result from these interventions. And looking at it even more closely, looking at the foresight, cerebral, and somatic oximetry, the tissue oximetry, we could see how even position changes, starting Levofed, and you can see in the middle of the graph, we started Levofed at a significant improvement, but then later on, additional increases in levoFed did not have much of an impact. So it does help us see almost in real time whether we're making an impact. And this is just a showing how when we started levoFed, approximately where this arrow is here in the middle. And this is, importantly, this is the screen that the nurses see, that the physicians can see in real time when you initiate a therapy. And you can see that with the levoFed, the SVR went up, stroke volume went down a little bit, cardiac index went down a little bit, and probably at this point it would have been helpful to give some fluid challenges to see if that made an improvement also. But again, you get real-time evaluation of your interventions. This is just an example here of where the vasopressin was utilized. It was actually turned off at this point, and we could see a gradual increase in the tissue oximetry numbers after it was turned off. This also is a good example of where vasopressin was being utilized. It was turned off, and then at that point there was a gradual increase in stroke volume by about 10%, a slight increase in cardiac index, a drop in the SVR, and a slight drop in the mean arterial pressure. All things that we would basically expect to happen, but certainly this confirms the effect of whatever you were doing. And ideally, in these circumstances too, you want to get these patients as euvolemic as possible. Another aspect of some of this technology is HPI, and that's hypotensive predictive index. And it really is picking up on subtle changes in the arterial tracing to give an early warning of a patient's potential hypotension. And we've actually utilized this in the operating room effectively to limit the amount of hypotension that we've been seeing and hopefully impact on our renal function. But again, you can see in this patient, there was where the red is in the HPI, there was a significant warning, and you can see that this was followed by a dip in the oxygen saturation, a dip in the mean arterial pressure, and even the cardiac index and stroke volume all had a decline. And again, I think this is supportive of the technology, as well as the fact that we can intervene early and hopefully minimize or prevent some of these events. And again, this is just sort of another way of looking at the data, and you can see towards the left where we gave albumin for an event, a hypotensive event. We can see the response, and even more importantly, even just one albumin had a significant response, but then there's this gradual decline, and then patient was prone and had another significant hypotensive event, and then was treated with fluids, and then had another unfortunate event, a GI bleed. But again, we're able to track these things and see how our interventions impact on patients' stabilization. Just another example, again, of our ability to give fluids and see a response, or giving vasopressor agents and seeing a response. The one thing that we have seen is problems when we obviously we're trying to prone these patients as much as possible, and we do see a response from the proning, but sometimes in the process of proning, we've seen patients have hemodynamic instability, which has limited our ability to prone them. And I think some of this is related to the fact that these patients are being run fairly dry, and we've been trying to utilize this to see if we can get them in a better euvolemic state before we put them in the prone position. And this is kind of an overview, almost a scorecard of how you're doing. And you can see, and this is just as an example, we were able to get our mean arterial pressure in this patient 76% of the time in the range we were looking for. cardiac index 94% of the time, and stroke volume 90% of the time. But it tells you whether you're improving or losing in your efforts to try to keep them in a good mean arterial pressure range. And at the same time, we can actually superimpose tissue oximetry numbers to also help us with this. So in summary, I would say that critically ill COVID patients are frequently older with multiple comorbid conditions. They're a heterogeneous group with variable presentation of symptoms. COVID positive critically ill patients frequently will require a fairly long intensive care unit stay to recover. If patients go on ECMO, they were frequently looking at 10 days to 2 weeks, even with just the ECMO. Real-time feedback of interventions allows for minute-to-minute management and may allow us to consolidate the ability to get patients into a stable state, even during some of these critical periods. Rapid optimization of patient fluid status may improve their outcomes and may actually reduce the incidence of renal failure that we see too frequently in these patients. Thank you.
Okay, thank you very much, Art, for this presentation. So we are going to proceed with some of the questions I see on the screen that's coming from the audience. One of the first question is for Dr. Kamdar. Nirav, does CMS pay for a phone consult? I thought they pay only for video consult. That's the question that was asked by the audience. I think you're muted. Yeah. I think you're on mute. Cannot hear you. Okay, so maybe in the meantime,
I think I'm ready now.
Okay, good. Sorry. Good.
So the CMS is reimbursing telephone visits at a much lower rate than that of video visits at this point. So the video visit has parity with the in-person consultation, and that's why from even our own data, we've seen a switch from largely telephone consultations to video visits.
Okay, a quick question I had for Monty and Art, I guess it's so we were at UCLA, we took care of some COVID-19 patients in the ICU, and then one thing that's really I've been extremely interested in is that I had never seen before is the self-proning. Patients were like spontaneously breathing, and that we started proning and spontaneous breathing, which I believe we don't know much about it. We know some about like the physiology of the prone position on respiration, but in ARDS, I never seen it before. What is your experience with this? What's the impact on hemodynamics? How can you tell the audience about? I found it personally fascinating, and then I'd like to hear your experience with it.
So it became very fashionable in the UK. I can only speak from anecdotally. I don't think we've had much written up about that yet, but it became relatively normal practice, both out of hospital and in hospital. So I mean, I think there's quite a long history of self-proning. I think it's called rollover darling for those gentlemen who snore when they lie on their back, and children often sleep on their front. But we then saw the introduction quite commonly in the pre-ITU setting of patients receiving high levels of respiratory support, being encouraged to lie on their front, and then they became quite good at doing it themselves because they found it more comfortable. And then that was supported by our respiratory therapists. So don't know about the specific hemodynamic effects because we weren't necessarily using advanced hemodynamic monitoring in those patients. But the fact that they made clinical improvement would suggest the fact that it was not deleterious.
And do you have any experience on non-invasive ventilation with this patient and their tolerance?
Yeah, we were very early adopters. It wasn't very fashionable at the time in London to use non-invasive ventilation, and in particular CPAP, continuous positive pressure, mask-delivered ventilation or hood-delivered ventilation, and high-flow oxygenation because of the fear of aerosolization. Whereas fairly rapidly our national guidelines changed to say we believe this is the right thing to do, and I think the data supports it has avoided intubation and mechanical ventilation for very many patients. And we were also, with regards to the supply chain of respiratory support devices, we worked very close with the Mercedes F1 team, and they helped us to make thousands of units to be able to deliver this mode of respiratory support.
I think there is also, at least in my experience, a link between telemedicine and the actual ICU management of this patient. Something we've seen a lot is the use of actually iPad, tablet to communicate with patient and family communicating with their family member in the ICU or in
Very much so.
the rooms. Yeah. So do you see that as something that's going to keep on continuing? How do you see the implementation of this kind of strategy in the future for patient care, COVID-19 or no COVID-19 era?
So I think culturally we've been relatively resistant because geographically we don't necessarily have the challenges in the UK. We're a tiny landmass, we're packed in, and getting to hospitals is relatively easy. And there'd been a cultural resistance to telemedicine in the intensive care unit. I can tell you after a week or so, we wish we were kitted up for telemedicine. And certainly, as you say, the use of iPads and phones to enable daily visits for relatives, even if it was a quick look around to, even if mum or dad was on a ventilator, to be able to have that connection to say, we can't let you in physically, but please do come in. So everything Dr. Kamdar said, I completely agree that it is, it was the brave new world. We've now decided to go into it.
And to dovetail on Monty's remarks, at least from the perspective of CMS, even interacting as a clinician across a window is considered a telemedicine visit. And so it's equal to that in terms of a billing code as that of actually walking into the room. I don't think it would be the same for critical care time, but certainly from a consultation period of history and history taking and physical, it would suffice.
And if I may, Maxime, come back on that, Nirav, I think that needs to be changed, because as we were doing a lot of remote support of rounds, we were definitely putting the hours in. And if those are non-billable hours, we have a different system in the UK, but I'm familiar with it from my time at Duke working on the critical care unit, that they need to be billable hours because they're high quality critical care, clinical care hours, and they're a very effective way of providing high quality care, I think.
And finally, maybe a last topic that I'd like to hear your thoughts about is we talk about telemedicine as a way to access patient in remote location or access patient behind a window so we don't take the risk of infection. But the telemedicine, in essence, it's a digital interface between a patient and a provider, right? And then you have today some solution that you start seeing being developed using computer vision, and actually from the images extracting physiological information on the patient, like measuring heart rate, measuring respiratory rate, measuring temperature, and things like this. Because the telemedicine, in essence, is this digital interface. Do you have any experience with that? Is there anything that you want to share with the audience before we close this session? We could see a system where on telemedicine you could, in a touchless way, measure blood pressure or cardiac output. Who knows?
I personally have no direct experience. I have indirect experience, and it's undoubtedly a field of rapid development, including some indirect experience of being able to look, as we know, at whole crowds and decide who watching the baseball game is developing a fever. You know, that technology is there. We just have to embrace it.
Okay. Thank you very much. I want to thank again Dr. Kane, the American College of Perioperative Medicine, and Edwards Life Science for their support of this webinar. And then thank you very much, Dr. Kamdar, Dr. Mythen, and Dr. Martella. Thank you very much, and see you next time. Bye-bye. Take care.
Bye-bye. Stay safe.
Stay safe. Yeah.